an audience and
on bladder cancer. And we are really fortunate to have Dr. Amit Ghosh as a moderator for this session. As he knows very well, today there are many parallel programs are going on all over the India. Many in Assam Urological Society's annual conference, in USI ISU conference, which are going on. So there may be little bit of distraction in attention in this great class. But still, I believe that we all will participate and all the students will participate to make this a great session. With this small introduction, Amita, I am not now in Nadiad. So I am handing over the session to you to conduct it in your own way.
Hello.
Yeah.
Hello.
Yeah.
We'll wait for another couple of minutes. It's 2 minutes to 7. Let me just wait for a couple of minutes. And I hope that Ritesh and Bikram and Piyush, all of you are here. Have you logged in?
Yes, sir.
I welcome Atanu Jana, who is also another teacher who's helping me in place of Debmanlo Gangopadhyay, who is out of action for a moment because of his personal reasons. So Atanu has kindly agreed to be with me. So we'll wait for a couple of minutes. And sorry, I got distracted. Is Ritesh here?
Yes, sir.
Can't see you. Anyway, okay, you are here.
Yes, sir.
Hi, yeah, welcome. Bikram?
Yes, sir. Yes, sir. Yes.
Where is Bikram? Where is Bikram?
Yes, sir.
Yep, okay. Piyush is there, I know. Yeah, Piyush, yeah, fine. And Atanu, you're here, thank you. Rojan is going to join whenever he can. I think he's busy with the Assam urology. I think we can start, isn't it? We are all here. Yeah?
Yes, sir.
Thank you, President, Dr. Kullan Sarkar, and thank you, Dr. Ranjan De, for arranging this humongous task of doing extensive CMEs for the benefit of the students and, of course, also us. We mustn't forget. However, my past experience tells me a harsh reality, and I'm going to share this with you guys. Whether you like it or not, it's going to benefit you. The experience is there's background noise somewhere. If you can just stop the background noise, whoever it's coming from. The point is, the CMEs are happening all over the country. You have to pass your exams. There's no point in trying to gather every bit of knowledge that you can. And there is no point in listening to every bit of information that happened last midnight. It is extremely important, I emphasize, that you get your basics of urology right and you can manage your patients in the outpatient and operation theater. That's what the examiners are looking at. I conducted a national program called Eurovidya, where we invited every examiner possible, senior examiner, all the senior faculty. The performance of all the students was very good, but there were huge lapses, which puts your life at risk as far as exam passing is concerned. When you're doing a bladder cancer symposium, I bet you know more than us. You know more than the teachers. Your enthusiasm, your intelligence at this point of time, your concentration is far better than the teachers and examiners. However, in the exam hall, you have to know urology. It is not bladder cancer, it's not hydronephrosis, it's not this, that, and the other. You know, you mustn't lose focus. Somebody's background noise is really disturbing. Can the admin look into this, please? Cannot conduct a class with so much background noise.
Nirmalo, please mute everyone excepting this.
I have muted. I have muted.
So why is the noise coming if you've muted it? So, so I think this is my understanding of what you should do. You may differ. But you know, it is probably good to listen to everybody and form your own little opinion about how you should conduct your life and your life as an examinee. Today's symposium is largely dependent on your presentations. We are not going to interfere too much, except for maybe a couple of questions here and there. Tomorrow is a massive teaching session. We will try and streamline that as well, so that we try and address the basics rather than we get into the cutting edge advancements which has happened last week or last night. Please listen to me. I'm telling you all this from direct experience. And this is a warning for everyone. DNB is a tough exam, particularly the theory exam. The fail rate in the theory exam is extremely high. There will have to be a mug pot. But as far as the Viva is concerned, you need to be extremely practical and patient-oriented. Shall I first of all ask Ritesh today to enlighten us about current status of immunotherapy in bladder cancer? Before you begin, I don't know what you're going to tell me. I want your opinion on what do you think, in summary, in one line, what do you think is the role of immunotherapy today's day and age in bladder cancer? Forget about your presentation. Tell me this as empirical form so that I can understand. You can understand that at my age, it's very difficult to grasp immunotherapy as well as you will do. But still, you tell me, what is your concept of the role of immunotherapy? Or, sorry, let me say, rephrase it. What is the role of immunology in bladder cancers as a urologist?
Okay. Immunology overall deals with the immunotherapy, like helping the immune system to clear out the bladder cancer cells. At this moment, for non-muscle invasive bladder cancer, the best bet we have is the BCG therapy. And for the advanced malignancies, we still have treatment for second-line therapy, like PD-L1 blockers, immune checkpoint inhibitors like PD-L1, PD-1 blockers. We also have cytotoxic antibodies, antibody therapy. We also have recent advancements like antibody checkpoints. So these are the things which are helping us, but still the best bet is.
No, there are three areas that I want you to tell me that where immunology is involved in bladder cancer. I'll tell you what I think. You correct me. That's the best way to learn. You will learn, I will learn. So the first area of immunology is immense advancement in biomarkers. Immense advancement. You cannot, it's an ocean of advancement whereby they are trying to find out it's not coming to rampant clinical use, particularly not in our country just now, but it's coming in.
Yes.
Number two, as you mentioned, is non-muscle invasive bladder cancer, second line of therapy. In some centers in Canada, they're using it as the first line of therapy because of the side effects and non-availability of BCG. BCG itself represents the earliest usage of immunotherapy in bladder cancer.
Yes, sir.
I agree. Finally, of course, in advanced and metastatic, as you have mentioned, PD-L1 and PD-L2 and checkpoint inhibitors. These are the three areas broadly that immunotherapy is playing its role. Today, your topic is on immunotherapy. So we'll leave out the bladder diagnostics.
Yes, sir.
If I were to design this, I would have definitely encouraged you to talk, but you must read up. Recent advances in biomarkers is a very hot topic now for your theory exam.
Yes, sir.
But let us concentrate on immunotherapy. Now, time is yours.
Okay. So I'll start sharing my screen.
Ranjan, I hope it's okay. Koldanda?
Yeah, it's nice. It's very good.
Carry on, Ritesh. Yeah, while you prepare, we were just chatting up.
Okay, so can you see my screen?
Only thing
No, I can't see yours.
Amita, I
Yeah.
have a small mistake. Today I have to mention that we have lost our past president, Dr. Anup Kundu, and we express our sincere condolences before at the beginning of the class to their
I remember this. I think he is very dear to our heart, and I felt that it will be proper that you have arranged a very comprehensive condolence meeting, and I think we should reserve the highest respect for him, and that is why I didn't mention it today.
Okay.
But glad you mentioned it.
Okay, thank you. Go ahead.
Okay, so can you see my screen?
No, I can't.
Yes, so now?
No? Can anyone see?
No, sir.
No.
Okay, so now it has started broadcasting.
No, it is not. Ah,
Now
yes, it's
okay.
coming,
Now
I think.
it's
Coming. It's not yet come, but it's coming.
Yes, sir. Okay, sir.
Not entirely. I think you're doing, I think it needs to be.
Sir, I'm sharing the PPT right now.
Whole screen is not coming. Yeah, better now, but you should make it full screen.
So it is full screen now. So can you see it full screen?
Yeah, come on. We can now. Carry on. Current
Sir,
status of immunotherapy in bladder cancer. That's what
Yes,
your heading is.
Yes, sir. Okay, sir.
Ritesh, please introduce yourself before starting your session.
Sure, sir. I'm Dr. Ritesh Satadi. I'm third year student at IPGMER Hospital in urology. So today we will be talking about the basics of immunotherapy in bladder cancer. Immunotherapy, as we know, it works to find out what is the part of your body. Immune system, it works to find out what is the part of your body and what is not. And it does it by fighting off the things that are harmful, like bacteria, virus, and cancer. Immune system is made up of different organs, cells, and proteins. Aside from the nervous system, it is one of the most complex systems of the body. So what is immunotherapy and how does it work in blood?
Carry on. Something happened? Hello, Ritesh?
Link failure.
Yeah.
We'll have to wait for a while.
I think these days it is important for everyone who sort of presents professionally in an academic meeting to ensure that they understand all the nuances of computer transmission and why things go wrong. And it does sometimes actually, even despite your best efforts, things go wrong. It should be part of the curriculum.
I think it's a part of the curriculum. It should be, yeah. If anybody has Ritesh's number, can we talk to him? I haven't got.
Sir, I'm calling, sir.
Okay.
Ask him to send you the presentation so that you can present it from your end, Nirmalu.
No, but he has to talk when he's not in connect. He's not in contact.
Why not ask the second person to be ready in case this is going to take time?
He's ready, I think. The second person is Bikram.
Yes, sir, I'm ready.
You're ready. So
But
shall we switch you?
No,
Speak to. Somebody speak to Ritesh, and then we can switch over.
Sir, I'm just calling, sir. The call has just connected.
Oh.
Sir, he is having some network issue. He is again rejoining.
Okay, if we then ask Bikram to take over. Ask him to
unshare the screen.
Unshare the screen, and then we can switch over.
Okay, sir. Okay, sir. Bikram, you can
Okay, I will share my
share the screen. Yeah.
Yeah.
Bikram, you also introduce yourself.
Right, sir. So is this screen visible, sir?
Yeah, it is. Yeah.
Good evening, everyone. I am Dr. Bikram Halda, third year PDT from IPGMR Kolkata. And my topic today is to discuss the bladder preservation strategies in muscle invasive bladder cancer. So bladder cancer is the 10th most common cancer worldwide, and it is the second most common genitourinary malignancy. At present, approximately 70% of the bladder cancers are non-muscle invasive and 30% are muscle invasive. So this therapy deals with the muscle invasive disease. The radical cystectomy with neoadjuvant chemotherapy is the gold standard treatment for muscle invasive bladder cancer. And this bladder preservation therapies in no way can counter that, or it does not replaces the main gold standard therapy of radical cystectomy. The problem is radical cystectomy is often considered to be associated with significant morbidity and mortality, with giving patients certain concerns when they are given this option. The morbidity associated with cystectomy has spurred a growing interest in bladder conserving treatments. Though there is no established criteria, but where bladder preservation therapy is given, there are some underlying criteria which they consider. They are the patients of two distinct categories are considered for bladder preservation therapy. First of all, one, those who are medically inoperable or unfit for surgery. And second are those who have organ confined disease, but have a strong preference to avoid radical surgery. There is no absolute size cutoff for tumors amenable to bladder preservation, but tumors larger in 5 to 6 centimeter in size can often preclude a bladder preservation surgery. Patients with hydronephrosis have much lower rate of complete response, and the 5-year disease-free survival is also low in them. And they often have to undergo salvage cystectomy post chemotherapy and radiotherapy, which further complicates the surgery and further prognosis of the patient. Some criteria which can be considered are some disease-related factors like small, low-volume solitary tumors, tumors that are of T2 disease, without any carcinogenicity, without hydronephrosis, without lymph node metastasis, and those tumors that are amenable to a complete transurethral resection. And some patient-related factors can be a favorable baseline bladder function and a normal performance status. Let's discuss first the monotherapies which are taken in consideration for a bladder preservation therapy. First is just a TURBT, or maybe a radical TURBT in this case. TURBT alone in muscle invasive bladder cancer is only possible as a therapeutic option if the tumor is just limited up to the superficial muscle layer and the restaging biopsies are negative for a residual or invasive tumor. Almost 50% patients still will have to undergo a radical cystectomy for recurrent muscle invasive bladder cancer. TURBT alone should be considered as a therapeutic option for muscle invasive disease after radical TURBT when a patient is unfit for cystectomy or refuses open surgery, or as a part of a trimodality bladder preservation approach. Maximal TURBT, which is a concept defined as macroscopic complete resection of the bladder tumor and the resection going down up to the detrusor muscle when feasible and when safely possible. It is critical to successful treatment in mono and multimodality therapies. Bladder preservation therapy with TURBT alone is appropriate for a small proportion of patients, as the criteria discussed earlier. The risk of recurrence is quite high. It can be up to 38 to 56%. So careful patient selection and regular cystoscopic follow-up is utmost of priority. What does the EU guidelines say about the recommendation? Still is not a recommendation, as only offering a transurethral resection of bladder tumor for a T2 tumor is not beneficial or does not satisfy the criteria of a curative treatment for this patient. Second is using radiotherapy as a monotherapy. Current radiotherapy techniques with soft tissue matching and image guidance.
No, Bikram, pause a minute. 1 minute. Before you pass on to radiotherapy, one question. You suggest radical TURBT, the muscle invasive tumor, as an option because patients are unfit for surgery. Okay? If patients are unfit for surgery, this is not a curative option. So you are going to confess to him that he is not going to get any other curative option.
Sir, if the tumor is primary, sir, in muscle, non-muscle invasive, we consider TURBT.
No. I mean, no. I'm talking about, we are talking about muscle invasive today, isn't it? Your topic today is bladder sparing surgery in MIBC, isn't it?
Yes.
So suppose you were in an exam and you suggested to the examiner, whatever's written in your books, I'm not bothered at this point of time. I'm just asking you a question as a patient. Suppose I'm the patient. I've got MIBC. I've got diabetes, hypertension. I've got a stent put in. So whatever criteria, bladder sparing term is for MIBC is one of the comments that Dr. Manoj Das has said in the chat box. I'm asking you, you are presenting an option, TURBT as an option. Can you justify that? If you can't, we'll talk about it tomorrow. Presentation for presentation's sake should be thrown out of the window. You must talk things that you believe. Everybody's got access to textbooks and literature. I know this is written in literature, but really do you think TURBT is an option? I'm just asking you a question. You can justify yourself.
So only using TURBT as a monotherapy is not justified, sir.
Exactly. So this is the first line that you will have to tell the patient. Anyway, we continue. We'll discuss this tomorrow again. External beam radiotherapy.
Yes. So the target total dose given to the bladder and for the bladder tumor for curative external beam radiotherapy in bladder carcinoma is around 64 to 66 gray. There is often a reasonable alternative to use hypofractionated EBRT, where in 20 fractions using larger doses, we can give up to 55 gray. Elective treatment to the lymph node by giving a complete pelvic radiotherapy is optional and should also take into account the patient comorbidities and the long-term risk of toxicity of this radiotherapy. Important prognostic factors that should be considered while expecting a response to this external beam radiotherapy monotherapy is the tumor size, presence of hydronephrosis, presence of CIS, or completeness of the initial tumor. Additional prognostic factors reported are age and stage of the patient. 5-year overall survival was around 48% in radical cystectomy and only 22% in the radiotherapy. In conclusion, although EBRT results seem to improve over time, EBRT alone does not seem to be an effective as surgery or trimodal therapy, but it can be an alternative treatment option in patients who are unfit for radical surgery or a concurrent chemotherapy. It also helps in controlling bleeding, which is another use. One study aimed to identify whether targeting the radiation to the tumor-bearing region only, as opposed to the conventional whole bladder radiation, whether it could improve the local disease control. But whole bladder radiation control arm had a better survival of 60%, 60-61% compared to the selective radiotherapy. Though the recommendations of using radiotherapy as a primary therapy in muscle invasive bladder cancer as a part of bladder preservation protocol is still not recommended. Third is using chemotherapy as a single option. Chemotherapy alone rarely produces any durable complete responses. Responses to the chemotherapy is a prognostic factor for treatment outcome and eventual survival, and it is always confounded by a patient selection and his response. A bladder conserving strategy with TURBT and systemic cisplatin-based chemotherapy would lead to long-term survival and intact bladder in a highly selected patient population. In a large retrospective analysis considering 1,538 patients were treated with TURBT and multi-agent chemotherapy, the 2- and 5-year overall survival for those patients were 52.6% and 36% respectively. Yes. Recently, a phase 3 trial has shown the presence of certain DNA damage response gene mutations, which are associated with better sensitivity to cisplatin-based chemotherapy, and it has spurred investigations about whether this can be used as an option for bladder preserving strategy. but still it is not recommended as a solitary treatment option for muscle invasive bladder cancer as a part of bladder preservation protocol. Now coming to the main therapy, which is often given to the patient as a part of bladder preservation protocol nowadays, is the trimodal bladder preservation therapy. The aim of trimodal bladder preservation therapy is to preserve the bladder and maintain a quality of life of the patient without compromising the oncological outcome. It consists of TURBT, chemotherapy, and radiotherapy. The rationale to combine TURBT with radiotherapy is to maximally achieve a local tumor control of the bladder as well as that of the nodes. The addition of radiosensitizing chemotherapy helps in potentiation of the activity of the radiotherapy. Micrometastases are targeted by platinum-based combination chemotherapy. There are still no successfully completed randomized control trial which compares the outcome of this trimodal therapy with radical cystectomy. But trimodal therapy using chemoradiation has been shown to be superior than radiotherapy alone. The 5-year overall survival for chemoradiation was 64% compared to only 45% for radiotherapy. In case of trimodal therapy, there are two distinct patterns of care. First is the treatment aimed at patients who are fit for cystectomy, who elect TMT or refuse cystectomy, and then patients who are older and less fit who are given this therapy. For the former category, the initial step is a radical TURBT, where as much as tumor possible is resected. In case of appropriate patient selection, particularly with T2 tumors without any carcinoma in situ, the response is seen to be better. Even in case of an initial presumed complete resection, a second TUR has often been suggested to reveal the presence of tumor in almost 50% of patients, which subsequently on its removal improves the 5-year survival in case of a trimodality therapy. For patients who are not candidate for cystectomy, less stringent criteria can be applied, but extensive CIS, poor bladder function are the relative contraindications. For radiation, two schedules have been used. One is a split course format with interval cystoscopy, and the other is a single phase treatment with cystoscopy at the end to follow up the patient. The conventional radiation dose includes an EBRT to the bladder and the pelvic lymph nodes for initial dose of 40 to 45 gray, with a boost to the whole bladder, and the further tumor boost to a total dose of 60 to 66 gray. And hypofractionation has already been talked about earlier. Different chemotherapy regimens have been used, but the best evidence are for cisplatin, mitomycin C plus 5-fluorouracil. Other regimens have also been used, like gemcitabine and hypoxic cell sensitization with nicotinamide and carboplatin. 75% freedom from distant metastasis has been reported in few studies at the end of 3 years. To detect the non-responders who should be offered salvage cystectomy, bladder biopsies should be performed after trimodal therapy. 5-year case-specific survival and overall survival is around 50 to 84% and 36 to 74%, but the salvage cystectomy rates are still high at around 10 to 30%. One of the algorithms suggested by some institute who preferred this multi-institutional study was showed that a maximal TURBT followed by a complete chemoradiotherapy should be given. Then a restaging TURBT should be done. If there is complete response, they followed up the patient for a relapse. And if there was incomplete response, this did a re-TURBT to see whether the residual tumor was non-muscle invasive or was again muscle invasive. If it was a non-muscle invasive, they repeated the TURBT and followed up with an intravesical therapy. Or if it was a muscle invasive tumor, they did salvage cystectomy. The differential impact of radical cystectomy versus trimodal therapy on long-term survival is still lacking. A propensity score matched institutional analysis has suggested that there is a similar disease-free survival and overall survival between trimodal therapy and radical cystectomy, but this is still debated. Overall, significant late pelvic, GI, and genitourinary toxicity rates after TMT are much low. Trimodal therapy is also associated with higher quality of life scores, including better social, physical, sexual, cognitive functioning compared to the patients who underwent radical cystectomy. A collaborative review came to the conclusion that bladder preservation with trimodal therapy leads to an acceptable outcome. Therefore, it may be considered as a reasonable treatment option in well-selected patients. The recommendations as per the EAU are offer surgical intervention or TMT to appropriate candidates as primary therapy or therapeutic approaches, since they are more effective than giving radiotherapy alone. Offer trimodal therapy as an alternative to selective, well-informed, compliant patients, especially for whom radical cystectomy is not an option or is not accepted. Another option is of partial cystectomy, which rests on the ability of thoroughly resecting the bladder mass while still preserving a functional bladder and maintaining the sexual function of the patient. With this procedure, as compared to maximal TURBT, a surgeon has the ability to more completely assess the surgical margin as well as perform a pelvic lymph node dissection if indicated. The factors associated with poor oncological outcomes are the presence of positive lymph nodes, lymphovascular invasion, need of ureter reimplantation, and aberrant histology. Across the series, the 5-year overall survival ranged from 53.7% to 70%, but advanced tumor recurrences were also high to up to about 40%. Because partial cystectomy incurs a risk of leaving behind a foci of cancer in the bladder with subsequent high rates of local recurrences, some series have to combine partial cystectomy with other modalities. Some of the other options that are available, like neoadjuvant chemotherapy followed by partial cystectomy, and a transurethral resection with chemoradiotherapy, followed by a consolidative partial cystectomy, sometimes loosely referred to as a tetramodal therapy, which is again gaining popularity for in a highly selected patient population. But the outcomes, there are some adverse effects and quality of life to be considered in such cases. Most of the trimodal therapy series demonstrated acceptable toxicities, but they can be a lifelong problem for some patients. Grade 3, grade 4 toxicities ranged from 10 to 36% in some series. The majority of the toxicities are GI and genitourinary tract related. Grade 1 and grade 2 toxicities can be up to 10 to 25%. And trimodal therapy studies have demonstrated comparable, if not superior, quality of life measures. This is largely driven by a patient's concern and their thought to retain their native bladders, with bladder retention possible ultimately in only 70% of the patient, considering salvage radical cystectomy required in this patient. There is a higher quality of life analysis shown in such patients. And furthermore, trimodal therapy patients have a significantly higher physical, emotional, social, and cognitive functioning, with superior bowel function and fewer bowel symptoms. And the quality of life study has shown that there is an increase compared to that of radical cystectomy. So to conclude, the interest in bladder preservation techniques have grown significantly over the recent years as a technological advancements, but improved bladder preservation therapy outcomes and the mainly focus on improving the quality of life of the patient. Trimodal therapy has the most evidence for its use, but the newer series demonstrating promising oncological outcomes compared to the radical cystectomy. Future directions and exciting areas of advancement include the use of tetramodal therapy, use of predictive biomarkers such as DDR gene mutations, and the promise of immunotherapy with subsequent bladder preservations. Thank you.
Very well presented. I think we do not have a question answer session, in spite of which I will ask Dr. Atanu Jana. But before Atanu comes into the picture, Vikram, can you tell me, if you've got a multifocal bladder tumor at the age of 70, who's wanting to preserve the bladder, would you suggest TMT to him?
Sir, first I will give him both the options, and
What?
biological age, I will assess the patient and assess his life expectancy with the help of frailty scores or with the help of Charlson comorbidity index, and I will assess the patient that whether he can tolerate major therapy such as radical cystectomy.
Anything else you will judge? We'll discuss this tomorrow. I'm just posing the question today.
Sir, whether he's also before.
Because you see, in my opinion, I'll give you one-line opinion and we'll discuss it tomorrow because we've got a session on this. In my opinion, whereas this whole thing was discovered and very favorably, TMT was discovered because of patient compliance. You said that you are doing alternative bladder preservation therapy in a category of patients who are unfit for surgery. You know, this category of patients who are unfit for surgery, there are strict guidelines as to which patients are going to be fit for chemotherapy also. We'll discuss that later, but it's a very tricky situation. Centers have shown equal efficacy of trimodal therapy along with radical cystectomy on the short term. I'm not discussing very much today, but severe reservations, particularly in our country, about TMT. That's my view. We'll discuss it again tomorrow. Atanu, to you.
Bikram, what is the radical TURBT? You have said the option of bladder preservation as a radical TURBT. So what is radical TURBT?
So radical TURBT includes a complete resection of the exophytic mass, including the muscle, and as much as possible up to the this capsule of the bladder or up to the perivesical region to exclude the maximum tumor that is possible.
So in a case of small tumor, you have to see that we have resected all the tumor and the perivesical fat should be visible. Okay, in these cases, it shows the only it's a superficial muscle involved, then we can observe the patient if it is not fit for radical cystectomy. So you have not said, you have said there's a partial cystectomy. So who are the fit, which tumor are fit for the radical partial cystectomy?
The partial cystectomy mainly depends on the location of the tumor. If it is located in a diverticulum or located in the dome of the anterior wall, where we can resect the tumor with a 2 centimeter margin, and we are able to close the bladder and to give him a sufficient bladder volume for further function.
Okay, if a diverticulum located at the near trigon, just behind the uretary orifice, can you do a partial cystectomy in these cases?
No, sir. In that case, it will not be possible.
Okay, so the location is a very important, and another is the size. Okay, if it is a less than 3 centimeter, then you can give a adequate bladder capacity. If you more than that, the bladder capacity will be not so much. So that will be a difficult one to preserve with the small bladder. Okay.
Okay, we carry on.
Yeah, yes.
We will have a session tomorrow. Thank you very much.
Yes.
It was a wonderful overview of all the options that you have discussed. I'm very sure that you know the limitations and you've pronounced it because they are there. But very well done. Who is ready to? Is Ritesh ready, or should we go to Piyush first?
Yes, sir. I can. I'm ready to share.
Who are you?
Ritesh, sir.
Ritesh, you're ready?
Yes, sir. Yes, sir.
Shall we come on then? Shall we do that first? Try and restrict it to 15 minutes if you can.
Okay, sir.
We're already running late. I don't like this, yeah? It's my fault, but whatever.
Sir, can you see my screen?
It's coming. Keeping us in suspense, but yes, it's coming. Yep.
Hello. Sir, can you see my screen?
Yeah.
Yes. Yeah. Carry on.
I'll start.
Yeah.
So, sorry for the delay. Good evening, everyone. Today, I'll be discussing about current state of immunotherapy in bladder cancer. Immunotherapy is the cancer treatment that boosts body's own immune system to fight the bladder cancer by destroying the bladder cancer cells. There are a few different types we are using. One is intravesical BCG therapy. One is using cytokines. One is immune checkpoint inhibitor, and one is monoclonal antibody. So, can you still hear me? Hello. Hello.
Yeah.
You are audible.
Okay, sir. Intravesical BCG, we'll just cover the history part. BCG is a live attenuated strain of Mycobacterium bovis. In 1929, Pearl proposed the antineoplastic effect of TB infection. In 1976, Morales described intravesical instillation of BCG. And in 1980, Lamb confirmed the efficacy of intravesical BCG for prophylaxis of TCC. The mechanism of action is beautifully illustrated in this diagram. It is showing that BCG acts by directly attaching to the fibronectin, which in turn activates the Th1 pathway and releases various interleukins, TNF alpha and interferon. BCG installation prerequisites for the technique. It is to be done 2 to 4 weeks after the tumor resection, which is the time for reepithelialization. Urine analysis and urine culture are to be performed. If the traumatic catheterization is done, that will be. Hello. Hello.
What happened?
Hello. Sir, can you hear me?
Yeah. Carry on.
Okay. Yeah. We should avoid traumatic catheterization for the patient, and we should ask the patient for fluid restriction of fluid and caffeine intake. Basic installation technique.
We don't want to know this. We do not want to know the
okay.
technique. Please skip these slides.
Okay,
we are wanting to know immunotherapy.
Okay, sir. Shall I say a few words about regimen or just skip it?
No, you don't need to say regimen. This is not the topic.
Okay, sir. Then going on further, sir, there are a few things about BCG immunotherapy. There's a new update which has been given. about giving intradermal BCG before giving intravesical therapy. The trial is ongoing, in which they have studied by randomization of the patients also in high-grade BCG naive non-muscle invasive bladder cancer. There were three arms. In arm one, intravesical BCG induction and maintenance was given. In arm two, intravesical BCG induction and maintenance was given with the Tokyo 172 strain. In arm three, they have given additional intradermal BCG. Where the concept of this study was prompted by the discovery that the priming with subcutaneous BCG prior to intravesical BCG installation boosted the response of BCG. So this is still undergoing the phase 3. And another update is that there is a severe shortage of BCG all over the world because Merck, who produced BCG for the all over the world, it has been working more than 100%, but there is still it does not meet the requirement by all over the world. So in response to that, there are various trials going on. People have tried to reduce the dose of BCG. People have tried to find alternatives, but still this is undergoing a lot of work. Now we are going on to cytokines. There are three cytokines under study or in use. One is interferon alpha, interleukin 2, and interleukin 12. Interferons are regulatory cytokines produced in response to antigen.
Hello. Hello.
Hello, Ritesh. Ritesh.
Ritesh has gone off again. Very interesting talk he was giving, but
I think, sir, Ritesh is having again network issue, sir.
can somebody talk to Ritesh?
I'm sir calling him, sir.
Hmm?
I'm sir calling him.
Yeah.
Sir, he is rejoining, sir. He's having some network issue with his locality, sir. So you are muted, sir.
We'll give him a chance. If
Okay. He's
I think
joining
we have
from here. So he's joining from his laptop. I think his iPod is having some problem. He's joining in from his laptop.
I think I'll be compelled to go on to the next presentation. I think we're getting late. We need to finish by 8:30 or so. Shall we do that? Is Piyush ready?
Yes, sir. I'm ready.
Let's ask him to unshare, and you please carry on. And we'll see if we can accommodate him for another 5 minutes later on. Yes, Piyush, you're talking on management of urothelial tumors of the upper urinary tract. Interesting subject. Yeah.
Good evening. I am Dr. Piyush. I am third-year resident from SSKM Hospital. Today, my topic of discussion is management of urothelial tumor of upper urinary tract. I'm not able to change my slide. Hello.
Your screen is visible, Dr. Piyush.
Hello. Hello.
Yeah, we can see your screen.
Yeah, we can hear you and see you. Piyush.
Okay. Okay, sir.
Go ahead.
Okay. So first talk about the incidence. The upper tract TCC consisting of 5 to 10% of all urothelial carcinoma, and it is mainly present in the 70 to 90 year of age, and is more common in 2 times more common in male as compared to female. It is multifocal in 10 to 20% case, with concurrent bladder cancer in 17% of cases. The most common way of presentation is hematuria, which is present in 56 to 98% of cases. And the second most common presentation is abdominal pain, which may be due to colic and the clot retention. And 10 to 15% of cases may be presented with advanced diseases in form of decreased appetite, anorexia, and 15% patient may be presented incidentally. So coming on the investigation part of that patient. So first come is the cytology. It does not provide any information on the site of origin of the malignant cell, and it is less sensitive for UTUC in comparison with the bladder tumor, but it gives at least 20% chance in a low grade And intermediate disease, it gives an idea up to 45%. And in a high grade disease, it gives an idea up to 70 to 75% of cases. Next comes out to be the radiology. CT urography with CECT KUB has the highest diagnostic accuracy. Its sensitivity for UTUC is 0.67 to 1 and specificity is 0.93 to 0.99. Finding the radiolucent filling defect, obstruction, or incomplete filling of a part of the upper tract, and even inability to visualize the collecting system. The urothelial carcinoma has an average density of 46 Hounsfield unit with a range in between 10 to 70 Hounsfield unit. For staging purpose, CT provides information on the extent of invasion, masses outside the collecting system, and presence of lymph node and the distant mets. Hydronephrosis, which gives an idea of advanced disease in 80% of cases. MRI is indicated in those patients who have iodine contrast allergy or can undergo MR urography. The sensitivity of MR urography is 0.75 after contrast injection for tumors smaller than 2 centimeter. CT urography is generally preferred over MR urography for diagnosis and staging of UTUC. And the third is cystoscopy. It is mandatory in every cases of upper tract TCC. It should always be performed because concurrent bladder tumor is present in up to 17% of cases. Endoscopy of the upper urinary tract is optional. It is only done when there is diagnostic dilemma, whether it is low grade or high grade, or when the disease is metastatic and we have to confirm the diagnosis with the biopsy to start the adjuvant therapy or neoadjuvant therapy. So antegrade endoscopic evaluation can also be done. It is recommended by EAU but not recommended by AUA guideline. There is low risk. When the low risk tumor inaccessible or difficult to manage with flexible ureteroscopy, they could be treated with percutaneous access. The percutaneous access approach is being abandoned because of the use of improved flexible ureteroscopes. Tumor cell implantation in the retroperitoneum and the nephrostomy tube tract should always be considered. The metastatic potential of upper tract UTUC is mainly by the directly extension into the surrounding tissue, secondly by the hematogenous spread to the lung, liver, thirdly by the lymph node metastasis, and fourthly by the concurrent field cancerization effect of the UTUC. Now the staging is always done by the TNM staging system. In this, the main thing is T3 for the renal pelvis. It includes the peripelvic fat and the renal parenchyma. And for the tumor, it is paraureteric fat. And for the T4 tumor, it is the paranephric fat. And the lymph nodes are N1 is more than 2 centimeter and less than 2 centimeter, and N2 is more than 2 centimeter. Right or left for any disease does not matter. This is the AJCC classification system. Now this is the prognostic factor. There are some factors which are present before the disease and which we get after the resection of the disease. So for example, if the patient is taking tobacco at the time and the tumor is located in the ureter as compared to pelvis, and there is surgical delay of more than 3 months, then these are some pre-operative bad prognostic sign for the patient. And some are post-operative. For example, high graded, high stage, concurrent carcinoma in situ, distal ureteral involvement, lymph node involvement, and variant histology in the specimen. So this is the main slide. We will categorize every patient according to these parameters into low risk and high risk category. First is the cytology. If the cytology is low grade or high grade, we will categorize the patient. Second is the CT scan. Presence of hydronephrosis, presence of mass more than 2 centimeter or less than 2 centimeter, multiple masses, lymph node involvement, any surrounding tissue involvement. These will categorize the patient into low risk and high risk. These all characteristics must be present in low risk category, but anyone present, if anyone of high risk category present, will categorize the patient into high risk category. If 3 factors are present of low grade, then again we have to go for biopsy in this patient, ureteroscopy followed by biopsy to further categorize the patient and to further confirm the patient that this patient is of low risk category. So this is the flow chart. If we are suspecting a case of UTUC, first we have to diagnose the patient with CT urography, urine cytology, and cystoscopy. Ureteroscopy with biopsy plus minus depending upon the case scenario. Then again, we will divide the patient whether the malignancy, whether the mass is present into the kidney or the ureter. And in the ureter, if it is present in the mid or proximal ureter or in the distal ureter. And same in the kidney, in the calyx and the renal pelvis. So depending upon the location, depending upon the risk category, the management will be done. So firstly, we will describe the management of localized non-metastatic low-risk disease. With improvement in current endourological techniques and equipments, kidney sparing surgeries allows preservation of ipsilateral kidney without compromising oncological outcome, and survival after kidney sparing surgery has been shown to be similar in Radical nephroureterectomy in low case diseases. Recommended kidney sparing surgery for all low risk diseases and do not be considered in selected and can be considered in selected patient with serious chronic kidney disease or solitary kidney. An important point when offering kidney sparing surgery in that patient, the patient must be willing to undergo repeated and stringent surveillance follow-up, including upper tract imaging, flexible cystoscopy, ureteroscopy, and urine cytology. So endourological management part, tumor of the upper tract can be approached in a retrograde or antegrade fashion. The approach chosen depending largely on the tumor location and size. In general, a retrograde ureteroscopic approach is used for low volume urethral and renal tumors, and an antegrade approach is preferred for large tumor of upper ureter or kidney and for those that cannot be adequately manipulated in a retrograde approach from this location. For example, lower pole calyx or previous urinary diversion case. The advantage of ureteroscopic approach is lower morbidity than that of the percutaneous and open surgical counterpart with maintenance of the closed system. With a closed system, non-urothelial surface are not exposed to the possibility of tumor seeding. The major disadvantage of a retrograde approach are related to the smaller instrument required. The newer generation flexible ureteropiloscopes are available in different size, 8 French, which made our life very easy. Flexible ureteroscope technical limitation such as small working channel that limit irrigation flow and diameter of the working instruments. Further limitation of flexible ureteroscopy includes reduced access to the certain area of the kidney, such as the lower pole, where the infundibulopelvic angle may limit the passage of the scope and prior urinary diversion. So when the tumor is confined only to the intramural part, then the complete ureteroscopic ablation of tumor or aggressive transurethral resection of entire most distal ureter can be done with acceptable results. Biopsy and definitive treatment, there are 3 general approaches can be used for tumor ablation. One is bulk excision with ablation of the base, resection of the tumor into its base, and diagnostic biopsy followed by ablation with electrocautery or laser energy source. Specimens are frequently minute and should be placed in fixative at once and are specially labeled for either histological or cytological evaluation. These are the 3 different techniques for taking the biopsy. Now the antegrade nephroureteroscopic approach, because deeper biopsy specimens are obtained, tumor staging as well as grading is usually possible. With a percutaneous approach, the established nephrostomy track can be maintained for immediate post-operative nephroscopy and administration of topical adjuvant therapy. The main disadvantage are the increased morbidity compared with the ureteroscopy and the potential for the tumor seeding outside the urinary tract. Distinct risks related to the percutaneous approach are loss of urothelial integrity and exposure of the non-urothelial surface to the tumor cell, possibility of tumor implantation in the nephrostomy tract. So cystoscopy is performed and the open-ended ureteral catheter is positioned as we do in the PCNL. Contrast material is injected and define the calyceal anatomy, and a percutaneous nephrostomy track is established through the desired calyx. This is again the same pictures. We are doing the RGP, and by seeing the filling defect, we are also electing the site for our puncture. Can be performed in 2 stages with establishment of first track and allowing this to mature over 1 to 2 weeks, followed by the track dilatation and treatment. If only a diagnostic procedure must be performed, such as evaluation of a positive cytology after cystectomy and diversion, the initial smaller nephrostomy tract may be used to introduce a flexible ureteroscope. Otherwise, a nephroscope is inserted and the ureter catheter is grasped, brought out the tract and exchanged for a stiff guide wire, thus providing an antegrade and retrograde control. Complete nephroscopy is performed with rigid and flexible endoscope when necessary. Any suspicious of ureteral involvement warranted antegrade ureteroscopy. So again, after identification of the tumor, one by one, with all those 3 techniques, we can biopsy the mass. These are the different techniques with cold cup, with laser, with the resectoscope. Now the second look nephroscopy. Follow-up nephroscopy is performed 4 to 14 days later to allow adequate healing. The tumor resection site is identified and any residual tumor is removed. If no tumor is identified, the base should be sampled and treated by cautery or the NdER laser at 15 to 20 watt for 3 seconds exposure. The nephrostomy tube can be removed several days later if all tumors have been removed. If the patient is being considered for adjuvant topical therapy, a small 8 French nephrostomy tube is left to provide access for the installation of the new adjuvant therapy. Some advise third look nephroscopy before removal of nephrostomy tube. Now the segmental ureteral resection. This is again a procedure of kidney sparing surgery. The segmental resection performed to preserve renal function in patient with compromised renal function must not compromise oncological efficacy for the sake of avoiding the morbidity associated with the dialysis. The advantage to a segmental uretrectomy are the ability to preserve renal function while also providing a pathological specimen that can inform the need and extent of adjuvant therapy. It is critical to evaluate the entire upper tract above the tumor with ureteroscopy to ensure that there is no multifocality. Now, open segmental uretrectomy with ureterotomy. The segmental uretrectomy for the mid and the upper ureter, the disease part can be removed and ureterotomy can be done. In this picture, there is mid-ureteral mass in which mid-segmental uretrectomy is done and ureterotomy is done. Now, the distal uretrectomy, if the mass is in the distal ureter, the distal uretrectomy is performed with the exception that the entire distal ureter and the bladder cuff must be excised and the posterior cystostomy at the bladder cuff is closed in 2 layers. The ureter is mobilized to achieve a tension-free anastomosis and spatulated. If an extravesical approach is desired, bladder detrusor muscle is incised, exposing the mucosa, and if the intravesical is, then the anterior cystostomy is made. If additional length is required, then the Boari flap can be used for this thing. Now, this is the case when there is no mass, but there is persistent positive cytology. In this, we will first do the cystoscopy, we will first do the CT urography and the cytology. If it comes out to be positive, then we will do the random biopsy from the bladder. And if the bladder biopsies are positive, then we will give the induction chemotherapy with BCG. And still, if they are positive, then we can do prostatic urethral biopsy and also the barbotage from the ureteric orifice. And in this way, we can confirm that there is some malignancy is present into the ureter because they cannot be evaluated with ureteroscope also. So if there is carcinoma in situ, in most cases, the diagnosis is one of the exclusion. There is persistent positive selective cytology in the absence of any ureteroscopic and radiographic finding. Treatment for isolated upper tract CIS is not well established. Radical nephrouretrectomy was performed in the past for a unilateral cytological abnormality of the upper tract. Topical therapy of the upper tract with immune therapy and chemotherapy via retrograde or antegrade approach with variable response rates. Most would not intervene initially with the surgical intervention in the absence of any histological, radiological, or endoscopic finding. Nephrouretrectomy is, however, indicated with radiological or endoscopic confirmation that the patient has more than just surface disease. Frequent interval re-evaluation with urine analysis, bladder and possible selective cytology, cystoscopy every 3 months, and retrograde pylography or uteropyloscopy every 6 months are indicated for 1 to 2 years. Surgical management in non-metastatic high-risk disease. The gold standard for the treatment of high-risk disease is radical nephrouretrectomy with bladder cuff excision. This may be approached with open laparoscopic or robot-assisted laparoscopic approach. Lymph node dissection, template-based, should be done in every high-risk patient. Management of distal ureter with bladder cuff in the radical nephrouretrectomy case. Complete removal of distal ureter with bladder cuff offers superior oncological outcome than to incomplete resection. The entire distal ureter, including the intramural portion and the ureteric orifice, must be removed. It can be done by different 5 methods. One is traditional open distal uretrectomy method. Second is transvesical ligation and detachment technique. Third is transurethral resection of ureteric orifice. Fourth is intersusception technique. And fifth is total laparoscopic technique. So by these methods, we can take care of the distal ureter and the bladder cuff. And the upper part is similarly done with the kidney and the upper and mid portion of mobilization of the kidney and the upper part of the ureter. So lymphadenectomy, there is still controversy surrounding the lymphadenectomy for the upper tract malignancy, but it should be done in every high-risk patient, which should be template-based. For the renal pelvis and the proximal or mid-ureter tumor, it most commonly includes the ipsilateral renal hilar nodes and the adjacent para-aortic or paracaval nodes and the pelvic nodes for the distal ureteral tumor. For tumor of the renal pelvis, this includes ipsilateral hilar, paracaval, retrocaval, and interaortocaval up to the level of inferior mesenteric artery for the right side tumor, and ipsilateral hilar and para-aortic up to the level of inferior mesenteric artery for the left side tumors. This is the template for the pelvis and the upper tumor. It includes the renal hilum and the lowermost boundary is up to the inferior mesenteric artery. For the mid ureter, the inferior boundary is up to the aortic bifurcation, and for the lower ureter, it includes the common iliac, presacral, obturator, internal iliac, and external iliac group of lymph nodes. In summary, although prospective studies are needed to assess the role and optimal extent of lymphadenectomy in UTUC, emerging data validates its importance in the treatment of this cancer. It is safe and beneficial for accurate staging and appears to have prognostic and therapeutic value in patients with invasive disease T2 to T4, especially in the setting of tumor of renal pelvis and proximal ureter. The adjuvant topical therapy in low-risk disease managed endoscopically, topical instillation of BCG, BCG plus interferon, or mitomycin C or thiotepa have been tried similar to the bladder cancer. However, unlike its bladder counterpart, there is insufficient evidence for current EUA guideline to make it recommended treatment. The controversial area are the modality of administration and its clinical effectiveness. There are currently 3 methods of installation of topical therapy in the upper urinary tract described by antegrade perfusion via a percutaneous nephrostomy tube, retrograde perfusion via a open-ended ureteric catheter, or an intravesical administration with degestant in situ with the mechanism of vesico-ureteric reflux. So the optimized delivery of mitomycin for primary UTUC study Olympus, the first sponsored trial specialty for UTUC. The study is in a phase 3 prospective open label single arm trial designed to assess the efficacy, safety and tolerability of the treatment of mitogel. The study is designed for low-grade, low-volume tumor, although the study is ongoing and results are not yet available. If found effective, well-tolerated and approved, mitogel therapy will significantly change the endoscopic management of low-grade UTUC by providing a viable therapy, not for only primary topical chemoablation, but also adjuvant therapy. Now, the adjuvant topical therapy for radical nephroureterectomy. So patient with upper tract malignancy have a 30 to 50% chance of developing recurrence in the bladder. So to avoid this, adjuvant intravesical topical chemotherapy after nephroureterectomy should be given. Perioperative single dose intravesical chemotherapy should now be considered as a standard of care for prevention of bladder cancer for nephroureterectomy. After surgery, now the systemic chemotherapy or neoadjuvant chemotherapy. Most studies evaluated on the platinum-based regimes. In 2018, significant strides were made with presentation of 2 separate prospective trials on the use of systemic chemotherapy. One a randomized adjuvant trial, the other is non-randomized GFR stratified neoadjuvant trial. The EA8141 confirms the efficacy of neoadjuvant approach with pathological endpoint, which are well accepted surrogate for survival. Once published in the peer-reviewed literature, it will be considered as an acceptable standard of care for patients with high-risk UTUC, and especially for those anticipated to have a post-operative creatinine clearance of less than 50. In 2018, the result of phase 3 randomized trial of perioperative chemotherapy surveillance in the POUT trial was presented after a trial was stopped early as a result of meeting predefined efficacy criteria. The study randomized patient having undergone nephroureterectomy with high risk of recurrence to adjuvant chemotherapy versus surveillance. Patient in the adjuvant arm received gemcitabine and cisplatin if postoperative creatinine clearance was more than 50, and gemcitabine carboplatin if it was between 30 to 49. The POUT trial is the largest completed for UTUC, and once published will establish the adjuvant chemotherapy as a standard for the patient with high risk of recurrence after nephroureterectomy. The 2-year disease-free survival results from POUT is inferior to the 5-year cancer-specific survival obtained from neoadjuvant chemotherapy in the Martin et al. Study. Although the latter was retrospective, its results was similar to those obtained from EA8141 trial. Further studies are needed to determine whether neoadjuvant or adjuvant therapy is superior. Now the treatment of,
are we close to conclusion?
Yes, sir. Only 5 more slides, sir. Treatment of lymph node positive metastatic disease. In that case, when there is evidence of regional lymph node mets, initial chemotherapy should be given as the primary therapy, and surgery should be withheld until a good, ideally a complete radiographic response is seen. Generally, 2 additional cycles can be given. The MVAC regime continues to have the highest response rate. So now some newer immunotherapeutic drugs, anti-PD-1, nivolumab and pembrolizumab, and anti-PD-L1, atezolizumab, avelumab, and durvalumab. These are also, there is no role of radiotherapy. And for the metastatic disease, there is no role of RNU, only when we confirm with biopsy, give the systematic chemotherapy. And these are some survival in we are seeing that 5-year survival. As the stage goes on, the survival decreases, and in T4 and metastatic and lymph node positive, the survival 5-year survival is less than 5%. So these are the EUA follow-up for the patient. Physical examination, urine cytology only in high-grade disease, and cystoscopy every 3 months for the first year, and every 6 months, then 2-year and 3-year. Contralateral imaging for the opposite kidney yearly basis, and the ipsilateral endoscopy when the patient has undergone organ sparing surgery, and metastatic evaluation in high risk patient with physical examination, chest X-ray, liver enzymes, CT urography, and bone scan if the alkaline phosphatase are increased. So these are my concluding slides. So guidelines for kidney sparing management of UTUC offer kidney sparing management in primary treatment option for patients with low risk category. Perform radical nephroureterectomy in patients with high non-metastatic upper tract urothelial carcinoma with removal of bladder cuff, with template-based lymphadenectomy, with installation of chemotherapy to lower the intravesical recurrence. And these are treatment for metastatic UTUC guidelines offer first-line chemotherapy in form of cisplatin, and if cisplatin cannot be given, then give carboplatin, and after that their role of immunotherapy comes. Thank you.
Piyush, very exhaustive presentation, very nice. As Professor Manoj Das from AIIMS, Bhubaneswar is commenting on the chat box that his presentation has been excellent. Tell me something. You have given us an ocean of information on upper tract urinary cancer.
Yes.
Suppose you have got a patient who is fairly fit, 62-year-old male patient, who has got 2 tumors in the kidney, just above 2 centimeters. And you're faced with the patient. When and how would you offer conservative surgery? I was brought up in urology all my life. I mean, everything is changing now.
Yes, sir.
Even UA is recommending low staged disease, low grade disease, you do minimally invasive. Have you done one? Have you done a nephroscopic approach?
No, sir.
Right. So that is the practical thing you need to learn.
Yes, sir.
Guidelines are guidelines.
Yes, sir.
They are good pictures for observing.
Yes, sir.
But you are here being trained to become a good writer in the theory exam and a good doctor in the practical exam.
Yes, sir.
Okay. I don't see, in my view, I'm making a very controversial statement for even if Manoj Das is watching, I'm sure he's watching. I'm making a controversial statement. If there are 3 or 2 tumors inside the kidney, 2 to 3 centimeters in size, very fit, I do not have the guts to suggest to him minimally invasive surgery. What are your comments, Piyush? And then I will ask the guest Manoj Das to comment on this, if you can, please.
I'm also agree with you, because basically this patient you have given the patient is also not fitting in the low risk criteria. There should be single tumor, and you are telling that there are multiple tumor. So
okay, single tumor, 1.5 centimeters, 45-year-old.
Okay. Yes, sir.
No comorbidities.
Sir,
I'm surrendering. I don't have. I'll send the patient to you.
Yes, sir.
Yeah.
In
UA guidelines to support you in the court of law.
Yes, sir.
Your conscience to support you that you spared the kidney for a 45-year-old. Good luck to you. Is Professor Manoj Das online? Can you? Yes. What is your comment, Manoj, please? Manoj, are you there? No, he's probably not there. He has commented on the chat box. That's very true. So I suppose he agrees to it. Otonu, over to you for 2 minutes if you.
Okay. Same question. Pelvic tumor around 1.5 centimeter. Would you go for a URS for a biopsy to confirm your diagnosis, or you go for a radical nephroureterectomy? In a 55 years gentleman presented with asymptomatic hematuria, on evaluation you have found on CT urography. What will you do? Piyush?
Piyush, can you hear him? Piyush is frozen now. I think we've lost him. While we are still, Piyush, can you reconnect? I think it's a horrible day today in Calcutta. Just to inform all the audience, we've gone through an extremely bad weather in the last 2 hours. It's still continuing. and my net has failed, so it's continuing on Wi-Fi. So there is a lot of trouble going on in Calcutta. So that is the information that I'm passing on. I will, in the meantime, while we are waiting for Piyush to respond, if he does, is Ritesh ready? Hello, Ritesh, are you there? I think the storm has made most of us disconnected.
I'm using my desktop, so there is no camera over here. So
Yes, Manoj Das has responded that MIS is for very, very selective group of patients. That's what the message is. Yes, everybody's got very Budogen has passed on a message, very unstable connection. We know there is unstable connection. Our luck is not favoring. But I think we need to make a very clear distinction. We are all dealing with agenda this evening, and that is what is, yeah, Piyush, you're back. Piyush, are you back? Piyush is connecting to audio. Piyush, are you back? Can you hear me?
Yes. Sorry, sir. Actually, some network problem is there because bad weather. Yes, sir.
Okay, Otanu asked you a question. He'll repeat it for you.
Yes, sir.
Okay, Piyush, there is
Yes,
a 55 years old gentleman, fit, non-diabetic, non-hypertensive.
Hello.
Citiurography shown. Hello.
Yes, sir.
Yeah. Citiurography.
Otanu, your thing is unstable. Yeah.
1.5 centimeter. Yeah. 1.5.
Carry on. We can hear you.
Mass, a pelvic mass. So what will you do? Will you go for a flexible URS, doing a biopsy, or you go for a radical nephrectomy?
No, I think he's off again. So I think we'll proceed. Ritesh is not there, I think. I think we'll have to cut short today's seminar for severe weather reasons in Calcutta. Ritesh is not there.
Sir, I'm here. Can you hear me?
Will you reconnect and make your talk short? We'll give you 10 minutes if you can highlight the essentials of your talk.
Yes, sir. I'm sharing a screen right now.
After that, I think I'll leave it to Otanu to do the. Piyush, are you back?
Yes, sir. Actually,
Yeah. While Ritesh is preparing himself, you answer that question in one line.
Yes. Sir, can you please repeat the question? Sorry.
The question is a 1.5 centimeter urothelial tumor, obvious urothelial tumor in a 55-year-old fit patient. What is your approach in the OPD? You're not facing the DNB exam now.
Sir, in our institute, if it is a pelvic tumor, then we will directly go for radical nephroureterectomy.
Okay.
But according to guideline, I will categorize the patient.
I have told you at the very beginning of the seminar, you have to be a mugpot to pass this exam in the theory. But you have to be an astute clinician and a urologist to pass the Viva exam in this DNB. Yeah? And that's the maturity we're expecting.
Yes.
Here, we are not here to exhibit our knowledge base. We are here to prepare you for the exam.
Yes,
okay?
sir. Yes.
Flaunting knowledge is for a different CME.
Yes.
All right? Yes.
Yes, sir.
We'll give another chance to Ritesh. Luck is not favoring him or us. Ritesh, be fast. Be skeletonize your presentation and give us the strong messages of immunotherapy. Please don't get into the details of how we will deliver and whatnot.
Last I was I completed inflation work. Now I'll go on for immune checkpoint inhibitors. Vital part of the immune system is to keep itself from attacking the normal cells. To do this, they use immune system checkpoints, which are the molecules in the immune cells that need to be turned on or off to start the immune response. Cancer cells sometimes use these checkpoints to hide from being attacked by the immune system. So immune therapy drugs which target these checkpoints are so-called immune checkpoint inhibitors. These can help in destroying the cancer cells. There are three types of immune checkpoint inhibitors in bladder cancer. One is anti-PD-1, another is anti-PD-L1, and the last one is anti-CTLA. There are various drugs of which FDA approval has been given. One is atezolizumab, first PD-L1 checkpoint inhibitor. It was approved by FDA in 2007. Sir, should I not read these details? Another is avelumab, adjuvant antibody against PTLR, approved in 2017 for use in carcinoma. Results of phase 2 trials show that avelumab induces a persistent anti-tumor response in patients with advanced urothelial cancer with tumor progress during or after platinum-based chemotherapy. Durvalumab, approved by FDA in 2017 for the same. Studies in the phase 1 and 2 patients have confirmed effectiveness in 20.4% of the patients. Nivolumab, approved by FDA in 2017. Phase 2 study was conducted with the patients of advanced bladder cancer survival, and the overall survival of 9.7 months was recorded. Pembrolizumab, approved by FDA, and ongoing phase 3 trials are there. It may induce immune-related adverse effects such as myocarditis or myasthenia gravis. First immune checkpoint inhibitor that could significant less overall survival. There are a few recommendations made by EE. One is there is strong recommendation of use of cisplatin containing combination chemotherapy with GC or SGM. There is strong recommendation to offer checkpoint inhibitor pembrolizumab to patients progressing during or after platinum-based chemotherapy for metastatic disease. This is the flow chart showing the treatment for advanced bladder cancer. In this, we can see for the progressive disease, the second-line therapy is immunotherapy. There's an immune checkpoint inhibitor, metastatic use of immune checkpoint inhibitor in metastatic bladder cancer. Atezolizumab and pembrolizumab showed in phase 2 and 3 trials to improve clinical outcomes through progressive platinum-based therapy. Atezolizumab failed to show overall survival benefit over chemotherapy in a phase 3 trial, and immune therapy improved clinical outcome for patients unfit for standard first-line platinum therapy. This is the timeline for the FDA approval. There are 2 landmark trials using immune checkpoint inhibitors as second-line therapy. One is KEYNOTE 045. It was over the pembrolizumab 200 mg IV. Primary endpoints were overall survival and progression-free survival, and it was FDA approved in 2007. Another is Javelin solid tumor trial. It was for avelumab, which was approved in 2007. The last one, Checkmate 275 for nivolumab. It was approved in 2007. These are the landmark trials using immune checkpoint inhibitors as a first-line therapy. Javelin Bladder 100, gemcitabine or platinum, followed by avelumab. IFD approval was given for the maintenance therapy in 2020. It showed improvement in overall survival of 21.4 months. There are the select phase 3 trials using immune checkpoint inhibitor as adjuvant therapy for MIBC. Checkmate 274 used nivolumab versus placebo. The primary endpoints were disease-free survival in all randomized patients and patients with PD-L1 expression of more than 1%. It met the primary endpoint, and FDA approval was taken in 2025. This is the timeline again. Now we are going to anti-CTLA-4 antibody. Cytotoxic T lymphocyte associated protein is a surface molecule expressed by activated T cells. It is a co-stimulant necessary for the activation of T lymphocyte. It negatively regulates immune response, but its mechanism is not yet fully understood. Ipilimumab is an anti-CTLA-4 antibody developed by Bristol Myers, used in combination with nivolumab for the treatment of advanced renal cell carcinoma and a different type of metastatic colorectal cancer. Studies on combining ipilimumab with PD-L1 or PD-1 blocks are in progress. Tremelimumab, anti-CTLA-4 antibody is being investigated again. And there are the few monoclonal antibodies. Enfortumab vedotin is being used. Antibody drug conjugate monoclonal antibody linked to chemo. Bladder cancer cells usually have Nectin-4 protein on their surface. This is the anti-Nectin-4 antibody. It attached to the chemotherapy. Antibody part acts as homing signal. It brings the chemotherapeutic drug to the bladder cancer cell with Nectin-4 on them. Similar, there is a Saxizumab govitecan. It binds to the conducting core again, and it used in the same way. It also went through drop to core. Limitations. This is influence the immunity of the patient. Intratumor heterogeneity of tumor, new antigen, tumor cell mutation in the target, and tumor mutation that significantly affects the therapeutic. Immune checkpoint inhibitors produce negative regulation leading to autoimmune diseases and even death. mTOR kinase inhibitors, everolimus and sirolimus are being investigated. FOX2 inhibitors, celecoxib is selective FOX2 inhibitor that is also being investigated. Take-home message in intravascular disease is more effective than TURBT alone, or TURBT and chemotherapy, non-muscle invasive bladder cancer. BCG is contraindicated in case of disrupted growth engine. Interferon is more effective as combined therapy with BCG and has benefit of reducing the BCG growth. Platinum-based chemotherapy is first-line treatment for advanced bladder cancer, and immune checkpoint inhibitors are second-line treatment. FDA has approved 5 immune checkpoint inhibitors: atezolizumab, avelumab, ravulumab, nivolumab, and pembrolizumab. More research is ongoing for CTLA, anti-CTLA4 and monoclonal.
Ritesh, well done. You've at least, where are you? Can't see you.
Actually, I'm using my desktop. There is no camera mode.
Very good. I think very good presentation. First, tell me, what is PD1 and what is PDL1?
PDA.
What are they? What is an inhibitor?
Sir,
what is it? Where is it?
Sir, can you? No. Sir,
can you hear me?
Program that I can run and program.
Yeah. Where is it? Where do you find them? What is it by nature? What is it? Is it a carbohydrate or what is it?
Sir,
is it a receptor? Is it what?
Sir, it is on the surface of the T cells and tumors.
Can't hear you.
No, sir, these are the transmembrane proteins which are present on the T cells and immune cells.
Which one is on the T cell? Which one is on the T cell? No, what I mean to say is, in your presentation, again, plethora of information, but what is the concept of it? What is the basic concept that you're talking about? You see, examiners are my age.
Yes, sir.
And we are really daft at this. You have to teach us. You have to pass the exam.
Yes, sir.
So what is a PD1 and what is a PDL1 and what is a anti-PD1? What does it do? Tell me, what does pembrolizumab do? Which class of drug is it? Am I right in saying PD1 is a protein which is found on the T cells? PDL1 is a protein which is a ligand which is found in the tumor cells?
Yes, sir.
Am I right?
Yes.
Why aren't you saying that? So what happens in nature is the PD1, PDL1 combination inhibits the T cell to destroy the cancer cells. Am I right?
So
this combination needs to be broken, and that's where the anti-PD-L1 and anti-PD-1 drugs have been invented.
Yes, sir.
Now, your talk doesn't clarify this. You have assumed we're all intelligent, we know everything. We don't.
No, sir. Initially, I shared in the PPT, there was a nice illustration.
Yes, but that's where your emphasis. It was a fantastic slide. You should have dwelt on it. Who wants to know how many 1,000 trials that are going on? You should have summarized the slides, the trials in one line, saying that there are trials going on.
Yes, sir.
In this category and that category. But second comment of mine is, do you find this at this point of time of any utility in bladder cancer treatment in our clinical scenario?
So, in Indian scenario, sir, these treatments are actually very costly.
Even besides the cost, Ritesh,
yes, sir.
This is coming into play in advanced bladder tumors,
Yes, sir.
mainly when you've exhausted your finances, your resources, your patients, and your prospects.
Yes, sir.
Please listen to me carefully. A patient who has got muscle invasive bladder tumor, you have first done a TURBT, you have put him on a check cystoscopy program, you have probably done some form of immunotherapy in the way of BCG or intravesical chemotherapy, gemcitabine or whatever. You've gone on doing this until you've reached a stage where you've done a radical cystectomy. Then he's come back to you on follow-up. He's recurred. You have now started him on. Can you look at the journey?
Yes, sir. Patient has already suffered a lot.
So you have to realize that your hands are tied, you're limited. Even 2022 doesn't give you the chance. I'm just trying to define where do we stand really beyond the CMEs in practice. As I'm not against, I'm not in any way campaigning against a PD-L1 inhibitor. I'm not campaigning against a pembrolizumab or atezolizumab because it has definitely shown a survival advantage in the short term. But whose survival? That we need to be very clear.
Yes, sir. The thing is that these drugs overall give a very small life, that too not to a very good quality life.
Exactly. So far, as far as we are concerned, the window of opportunity of immunotherapy besides the BCG, the role of immunotherapy worldwide is extremely limited, whatever the pundits might say.
Yes, sir.
So we must position ourselves very well. Let us be very clear in our mind. Patients have got every right to deserve every bit of advanced treatment that we possibly can give to them. But we must know what we are dealing with and how much life expectancy we are offering to them at the financial cost that is there beyond clinical trials. Anyway, it was a very good. I'm delighted that you are really, really up to date. I am not. So I learned a lot of things from you. I will now, because of the very, very bad weather condition, I have invited Atanu Jana to go through radical cystectomy discussion. The video is not going to play. We have had a wonderful video to show you, but I'm sure all of you have done lots of cystectomies by now or have witnessed cystectomy by now. So Atanu, can you please take over and go through them on a discussion of radical cystectomy? That's the best we can do. Okay. And after that, Atanu will close the session because I will have to leave extremely poor condition of weather in my area. Atanu, please carry on and take over. Sorry for the inconvenience. We'll meet you again tomorrow.
Okay. So
now, one of the students must, two or three of the participants who, Ritesh, Bikram and Piyush, please take turns and have a good discussion, thriving discussion of radical cystectomy. Basic steps. This is what is going to give you the license to pass the exam. Please remember, don't make mistakes in basic things like radical cystectomy. So Atanu, starting from anesthesia to positioning to incision and the steps. I think Atanu is an expert on radical cystectomy. I don't know how many of you know that, but I'm sure you'll be delighted to get taught by Atanu Jana this evening. Over to you, Atanu.
Thank you, sir. Okay, Bikram is there?
Yes, sir. Yes, sir.
Okay, now we started with the indication of radical cystectomy. So tell me, what is the indication of radical cystectomy?
So the primary indication of radical cystectomy would be muscle invasive disease, at least stage T2 and beyond. But there are also certain indications of radical cystectomy in non-muscle invasive bladder carcinoma, like those patients with very high risk bladder carcinoma as per the EORTC risk staging.
Okay, so just tell 2 or 3 points. Who are the very high risk group?
So very high risk patient will be one with a T1 high grade tumor with carcinoma in situ, and at least one preclinical risk factor like age more than 70 or a size of tumor more than 3 centimeter or multiple tumors.
Okay.
And another example.
What about? Yeah.
Yes, sir.
Tell.
Yes, another example would be a T1 high grade without carcinoma in situ, but having all the three risk factors like age more than 70, size more than 3 centimeter, or multiple tumors.
Okay. So what about the BCG failure group?
Yes, so for BCG failure, particularly BCG unresponsive patients, BCG refractory patients will also be an indication for radical system.
Okay. So when you term a patient is a BCG failure?
So, BCG failure would be a patient who has a recurrence of a T1 high grade tumor after at least 3 months of BCG regimen, and further continuing treatment would increase the chance of his recurrence. It would be also in a patient of a TA high grade tumor who has a presence of a tumor at least 3 months after induction after BCG regimen, and also after 6 months after BCG regimen, or after reinduction phase, or a persistence of a carcinoma in situ in this similar pattern, or reappearance of any high grade tumor while undergoing a maintenance therapy.
Okay. So you want to do a patient in a radical cystectomy. Okay. So what will you look for a prostate?
So as a general examination of the patient, while examining the patient, I will also in a male patient look for the prostate, whether there is any palpable nodule or whether there is any suspicion of any feature that may point towards a prostatic malignancy. So ideally, we do not prescribe PSA for evaluating this patient. Only as a part of staging investigations while evaluating the patient, whether during a CT or MRI, whether any suspicious lesion is seen, then we'll evaluate the prostate along with it. But so most of the time we do a radical cystoprostatectomy where the entire prostate is also taken out with the bladder. So we generally do not evaluate for that.
Okay. So now, Piyush, what will be your pre-anesthetic checkup for this group of patients? Piyush, are you hear me?
Yes, sir. Yes, sir. Yes, sir.
Okay. Just tell me the important step of pre-operative preparation.
Sir, as we are doing a big surgery on this patient, so I would like, and we are also using planning to use the bowel for the conduit part or the orthotopic part. So I would like to check for the general anesthesia for the basic investigation in the form of CBC, liver function test, and protein profile, albumin, and chest X-ray, and chest X-ray coagulation profile.
Okay, that is we all check the pre-anesthetic while different investigation which we already do. Okay.
Yes, sir.
So what will be the preferred anesthesia for this group of patients?
Sir, general anesthesia.
Along with anything?
With
yes.
Epidural anesthesia.
Okay. Okay. So usually we prefer the general anesthesia with epidural because the epidural serve two purposes. One is the post-operative analgesia, and as well it also requirement of the anesthesia also, because it's a prolonged time. So the prolonged anesthetic drug may require for this patient. So we usually prefer a epidural anesthesia also along with the general anesthesia. Okay. So would you prepare the patient prepare the bowel of the patient or not?
Sir, in our institute, we used to prepare the bowel. We keep the patient on, yes, sir.
Just tell how we prepare the bowel for this patient.
Sir, we start the semi-solid diet 48 hours prior to the surgery, and plain liquids day before the surgery.
Okay. So what about the bowel, the cleansing enema or like this thing?
Sir, we usually give Peglet 1 day prior with the clear fluids.
So what is the recent literature says about this, whether bowel preparation is required at all or not?
Sir, it only decreases the total load of the bacteria, but per surface area.
But for the gut anastomosis, nowadays they say it is not required. But when we are connecting the urinary tract with the gut, they are saying doing a bowel preparation will decrease the chance of pyelonephritis. But there is no strong evidence of that, whether it is beneficial or not. Okay. But in our routine practice, we usually do a bowel preparation for all these patients.
Yes,
okay. So now tell me about that. We have anesthesia, the position. What will be the preferred position? In a supine position, if anything in supine position, we all do. There is anything extra we have to do?
Yes, sir. We generally extend, basically flex the part so that the area between the pubic symphysis and the umbilicus increases, and there is stretching, and the basically working area increases.
Okay, why increases? Okay, and head of the table will be slightly down, so that the bowel which is coming in the field, you can be go towards the upper abdomen. Okay.
Gravity can
so,
go upward.
What will be your incision? Tell me about the extent of the incision.
Sir, below umbilicus, start just below the umbilicus, and sometimes when we excising the urachus part, basically, then just below the umbilicus till the pubic symphysis.
What about the Bikram? What we have shown?
Sir, he is also right, sir, but sometimes we increase the incision above the umbilicus also, sir.
Okay. Usually we put incision above the umbilicus because we have to remove the urachus along with the whole of the peritoneum along with the anterior bladder wall. Okay. So incision usually extended 2 centimeters above the umbilicus. Okay. So whether you will enter, you have seen whether it's an intraperitoneal approach or an extraperitoneal approach first.
Sir, first it is, sir, we excise the urachus part first.
Okay.
So it is extraperitoneal initially.
Okay. So when you are excising the urachus, that means you are entering into the peritoneal walls. Huh?
Yes, sir. But we start from.
So there is a two school of thought. Okay.
Yes.
Some prefers just go anterior to the bladder, that is in space of Regius. Okay, and started the dissection from the dividing the vas deferens and the anterior to the bladder up to the prostate. Okay, and there is another school of thought who is there dividing the urachus from the initial period, entering into the peritoneum itself also. Okay, so what will be the lateral extent of excision of urachus?
Medial umbilical ligament.
Whether it's a medial or lateral, usually we remain lateral to the medial. The medial and lateral, we usually remain lateral to the medial umbilical ligament. Okay. So now tell me the next steps. So you started to divided the urachus along with the lateral incision along the lateral aspect of the medial umbilical ligament. So which structure will come in the lower down in the pelvis? Vikram?
So do you mean anteriorly, sir?
No, you are going down towards the bladder. There will be the one structure coming in between your dissection. Very important. You have to identify this structure during the dissection.
Intraperitoneally, then, sir, vas deferens.
Yes. So it is the next our anatomical landmark to identify is the vas deferens. Okay. So we found the vas deferens and divided it on the both sides. Now we reach up to the upper border of the bladder. Now what step will we follow?
So we can go for an anterior approach or a posterior approach, where we can anteriorly drop down the bladder, mobilize the bladder laterally, try to access the superior pedicle and the lateral pedicles, anterolateral pedicles, and try to go towards the neck of the bladder.
Okay. Just after the division of the vas, when we reach to the up to the upper border of the bladder, next step we identify the both sides of the ureter. Okay, that's a very important point because so where we identified the ureter.
So where it crosses the distance.
Okay, so we identify the ureter and dissection carried out up to bladder hiatus of the bladder. So what important vascular structure lie there at the hiatus of the bladder where the ureter enter into the bladder? There is a very important structure. In radical cystectomy, bleeding occur in 2-3 places. It is the one region where bleeding may happen. So it is the superior vesical pedicle. Okay, Piyush?
Yes, sir.
The superior vesical pedicle. Until you divided the superior vesical pedicle, we will not able to reach the hiatus. Okay. Right side, we can sacrifice some amount of ureter there, but on the left side, you have to keep as much as possible of the ureter. Otherwise, it's very difficult to reach if we put a ileal conduit, reach behind the sigmoid colon mesentery.
Yes,
So
sir.
after that, we divided the ureter on the both sides after division of the superior vesical pedicle. Now we can go anterior or posterior. So if we want to go posterior, what will you do? What structure will you face next?
So posteriorly, we'll face the peritoneum, which is covering both the surface of the bladder and the rectum. We try to incise it above the level of the seminal vesicle and stay close to the prostate and stay close to the bladder and the seminal vesicle. And we try to create a plane between the rectum and these structures. We try to protect the rectum.
So some prefer to put a flatus tube before the operation to identify the rectum. Okay. So you have to identify the both sides seminal vesicle here. That's a very important. Okay. When you identify the seminal vesicle, just carry your dissection just behind the seminal vesicle and is protecting the rectum. Okay. So what will be the next structure will you find when you carried out dissection posteriorly?
So next, as we go below, we'll encounter the Denon-Villers fascia, which acts as the interface between the rectum and the prostate and seminal vesicle.
Okay. So it's a very important step to identify the Denon-Villers fascia. If you identify, you have found the Denon-Villers fascia, and always keep to try. In the textbook, they have literature, there's a 2 layer of the Denon-Villers fascia, but it's a very difficult to identify. So usually we remain anterior to the Denon-Villers fascia always to prevent the rectal injury. Okay, so that is the extent, that's what division of the Denon-Villers fascia. We stop there because there are posterior division, posterior dissection is completed here. Okay. Now what about the anterior dissection?
So anteriorly now we have to approach the DVC, so it incises the endopelvic fascia. And after dissection of the endopelvic fascia on the either side of the midline, we'll encounter the superficial venous plexus above the bladder, and we'll try to proceed it up to the dorsal venous complex.
Okay.
And so also there will be in front there will be the puboprostatic ligaments, which we will divide.
Okay.
And then sir will ligate the dorsal venous complex.
Okay. So it is the important step is there, the identify of the endopelvic fascia. Incision of the endopelvic fascia is very important. We just give lateral. Okay. Otherwise, there's a vein from the DVC is called side of the prostate, which can injure during the giving the incision fascia. Okay. So after putting a incision on the endopelvic fascia, we go and also divided the puboprostatic ligament. Until you divided the puboprostatic ligament, the control of the DVC will be very difficult. Okay, so you have taken a control on the DVC. Okay, now what will be the next steps? How will you proceed? Your anterior dissection is completed, posterior dissection is completed. Now it is only lateral dissection. Okay, so which energy source is required for, which is best for this lateral dissection?
So lateral dissection, if we are planning for a nerve preserving procedure, as in this case, the
I'm asking about the what energy source you will use.
So harmonic would be a better choice than a monopole.
Okay, so any kind of the vessel sealer. Any kind. Hello?
Yes.
Any kind of the vessels, either it may be ligosure, either it may be harmonic. Okay. Otherwise, we have to tie in the every steps. So now your lateral dissection is completed. Now, how will we divide the prostate and urethral junction? Any specific tips or tricks is there?
So we generally keep the bladder half filled, and then we push the bladder with the help of a retractor, so that the apex of the prostate and
No,
the junction of the prostatouretary.
Usually we keep bladder in empty. If you full half bladder, full the bladder, the space will be very difficult to manage. So very minimal space in the pelvis is there. We first tuck on the catheter, so we identify whether bladder and prostatic junction, and keep a traction with 2 fingers over the prostate to reach the apex. And we give a anterior incision first, identify the bladder, identify the catheter there, dissection posteriorly. Okay. So what will be your next step after removal of the, you have removed the bladder. Okay, you have secured the hemostasis there. So next, what will you do? In a radical cystoprostatectomy, after removing the specimen, what is the next step?
So I will complete the bilateral standard pelvic limb dissection. So
what is the boundary of the standard pelvic limb dissection?
So in standard pelvic limb dissection, the lateral boundary is up to the genitofemoral nerve. Medially, it is the internal iliac. Below it is the Cooper's ligament. Above, below it is the Cooper's ligament, and above up to the bifurcation of the common artery.
Okay. Okay. So we have done the bilateral. So what will be the extended lymph node dissection?
So extended lymph node dissection includes the lymph nodes over the common iliac vessels up to the bifurcation of the aorta, and also the presacral group of.
Okay. So what is the standard now? What is the standard practice nowadays? Whether it is the standard lymph node dissection or the standard extended lymph node dissection?
So in our institute, sir, we practice standard, and the literature which we have noted is that the outcome of the standard lymph node dissection is almost comparable to extended lymph node dissection. So we still prefer standard.
Okay. So, and according to the patient choice and our patient preparation, we will go for the ileal conduit or a neobladder. Okay. So, anything you want to know about the radical cystectomy more?
Also, sir, yes, sir, whether the tumor was involving the bladder neck or the tumor is involving the prostatic urethral mucosa, and if such facilities are available in such situation, we'd like to send the frozen section analysis of the distal extent of our resection so that we can prepare the patient for an orthotopic neobladder.
Okay. Thank you. That's all. In a basically in a today's environment, the net connection is a very poor now. Okay. So I will ask Dr. Day to conclude the session. Sir? Nirmallo? Nirmallo?
बोलो
बच्चे डॉक्टर रंजन देव की साइड के बोल सर
उन्हें बोल
Hello. Hello.
Good. Thank you very much, Dr. Ghosh, for this exciting evening. And we really enjoyed the session. I also thank Otonu for wildcard entry and give a support to the education of the East Zone. Tomorrow we
No,
all
sir.
will hope to meet and have a very extensive session on the bladder cancer. And Dr. Brojen, in spite of his preoccupation with the Assam Urological Society, he has also participated well. Thanks all of you. With the expectation tomorrow we will meet in time and we'll enjoy the product. Thank you once again, all the students, all the teachers and the moderator. Thank you. Bye-bye.